Hello there. Thanks for your patience in getting started. It's a delight to be with you today, and I'm Dr. Jeff Curtis. I'm very pleased to have the opportunity to go with you over the next several minutes to address proactively some information that I think may be helpful to you and the rest of the lupus community. The goal of the next half an hour or so is to both answer questions but have up-to-date information about COVID and COVID vaccination, particularly from the perspective of a patient provider who treats lupus and other inflammatory and rheumatic diseases, rheumatoid arthritis, etc. But we're going to have obviously a particular lupus flavor. I'm a professor of medicine and rheumatology as well as epidemiology at the University of Alabama at Birmingham. Just to give you my background and sort of why I'm here with you today, I'm a rheumatologist and originally from California, actually grew up in Northern California and then lived both in the Los Angeles, West Hollywood area, as well as went to school in San Diego. So my roots are the same as many of you's in California. So I have the privilege to be the American College of Rheumatology's Guidance Task Force lead to be able to help develop guidance or guidelines, if you will, on behalf of the ACR, the National Specialty Society for Rheumatologists and their patients throughout the United States. About 6 to 9 months ago, and even probably before that, the ACR recognized that both on behalf of its members as rheumatologists as well as the constituency that they serve, their patients, that there was going to really be an important need to bridge the evidence and evidence gaps around what to do regarding COVID vaccination. You know, there's not a whole lot of information at the time, and there's only a little bit more that provides direct evidence about how we should best be thinking about vaccination for patients with lupus and other rheumatologic conditions. So the ACR convened a task force to review all the evidence, and then the evidence, be that as it may, scant, that might be specific to rheumatology, and help summarize it to help rheumatologists and patients. To do that, they convened 9 rheumatologists, including myself, 2 infectious disease experts, and 2 present or former Center for Disease Control public health experts. I'm the chair of this committee, and there was a huge amount of work that went into this starting in the late fall and then over the holidays, and it has continued since. Our charge from the ACR was that the 13 of us would develop clinical guidance for rheumatology patient management on how to best use vaccines and how to best implement vaccination strategies for at-risk rheumatic and musculoskeletal disease patients. The target audience was rheumatology providers and their patients. And although the ACR does a whole lot of advocacy and education, this was really intended to focus very narrowly on how to think about vaccination. The other things they do, advocacy, access, things like that, those are done by separate guidelines and committees. We developed a 70-page evidence report, and then there's a formal process about how guidelines and guidance statements are developed by the ACR, where we try to achieve consensus. And there were a total of 76 statements and positive assertions that came out of this process. My purpose today is to go through some of the highlights that directly address many of the questions that you pre-submitted, and then to also have the opportunity to field questions that may not have been fully addressed in my next several minutes of comments. So let me go through some of the guidance statements, and we're definitely not going to get to all 76 of them. I'm happy to post in the chat window the references just because they are publicly available. They're a little bit dense, frankly, but this allows you to be able to access the PDF, and I've posted that just now in the window. You may find it more useful, frankly, to refer to it after the fact, just because there is a fair amount of jargon, and hopefully I'll unpack some of the detail for you. So the first question that I think is really of critical importance is to understand what the risk is for patients with lupus and to understand whether that risk can be mitigated by COVID vaccination. So the first statement I want to address is related to the ACR's guidance statement that says that patients with autoimmune and inflammatory rheumatic diseases, if you did refer to the PDF, that's this abbreviation AIIRD, but for now we'll just call it lupus patients because that would be kind of a prototypic example. You know, lupus patients are at higher risk for hospitalized COVID-19 and worse outcomes compared to the general population. So unpacking both those two things is pretty important. Higher risk for hospitalized or bad COVID and worse outcomes. The reason, of course, that that's so important is that if that's true, then you would expect, well, then lupus patients should be prioritized for vaccination. That's another separate statement. And what that really is intended to do is that I and my 12 colleagues, as well as the ACR, wanted to be able to elevate lupus patients in the priority queue to get vaccination if they wanted it a little bit higher than, the general healthy population. As you may be aware, the Center for Disease Control made recommendations that for anybody with a long-term or a chronic condition, that probably they should be prioritized to get early access to the vaccine for those that choose to take it. And so this statement was intended to help facilitate that. If you look at population-based evidence, not just one little medical center, one doctor's office, but large groups of people, and a lot of this data is coming out of Europe, where, for example, you can study the whole country of Denmark, for example, and, patient data is linked to a variety of databases that they have in some European countries. It looks like patients with lupus, as well as other rheumatic conditions, rheumatoid arthritis, vasculitis, have about a 1.5 to a 2-fold increased risk for hospitalized COVID. So, 1.5-fold elevated, maybe doubling of the risk for hospitalized COVID. And it seems like they probably have worse outcomes. So that's the underpinning of, I think, what causes concern for everyone in the lupus community, and certainly people like me that provide care to people in the lupus community. And that's really focuses the spotlight on why vaccination is so important. Another important topic that's worth discussing is to recognize that we expect we can mitigate that increased risk for COVID with vaccination. That said, the expected response to COVID vaccination for many lupus patients that are on immunomodulatory or even immunosuppressive therapies is probably blunted in both its magnitude and duration compared to the general population. So the notion here is that probably the vaccine isn't going to work quite as well, and it may not last quite as long compared to the general community. That said, it's really important not to overread that statement. And I have this discussion quite frequently with patients who immediately might say, hey, let's take a step back. If you're telling me this vaccine might not work as well or last as long, and there are some at least potential safety concerns, maybe this just isn't for me. I think that's a fair statement, but let's unpack that a little bit. In large population-based studies with tens of thousands of people, this vaccine's efficacy is as high as 90 to 95%. We don't have that data for patients with lupus or rheumatoid arthritis or vasculitis or frankly any other rheumatic disease condition. However, even if it was only, say, 70% as effective, I take 70% effective over nothing, and you get nothing if you choose not to be vaccinated. So a lot of protection may not be quite as good as 95%, even if it was only 70, 80%. I would still feel pretty good about recommending vaccination. Some protection, even a lot of protection, is a whole lot better than nothing for people who choose not to be vaccinated. And in fact, there's nothing unique about COVID vaccination in lupus. In fact, the vaccine response to almost any vaccine is not quite as good as in people with lupus than in folks who have no rheumatic or inflammatory disease. So there's nothing particularly wrong or bad or less effective about COVID vaccination. In fact, 90 to 95% effectiveness for a vaccine, that frankly is fantastic. Flu vaccination effectiveness is in about the 20 to 60% range. So if you're starting 90 to 95% with COVID vaccination, as we are for the mRNA vaccines, we're doing really well. The other side of the coin, of course, to consider is the potential for a lupus flare or disease worsening. So that definitely is a consideration with respect to anyone who has an autoimmune disease. Why is that? Well, the reason is that remember how vaccines work. Vaccines are going to rev your immune system up, and at the same time, they're going to expose you to something. In this case, part of the COVID virus itself, the outer part, the jacket part. There's no risk you can get COVID with the vaccine, but they're going to take a piece of it. That piece can't replicate, it can't cause disease, it can't cause infection, but they're basically going to rev your immune system up at the same time as they expose you to part of the COVID virus jacket. Now, you might say, well, I have an immune system problem. I don't want my immune system revved up. That would be a perfectly understandable reaction. So that's where the concern about disease worsening or flare comes in. That is a very credible concern, and I would endorse people at least thinking about that. However, that said, it doesn't look like that is really playing out as being a major problem in large numbers of patients. Here, admittedly, we have a lack of evidence. We don't have studies of hundreds or thousands or tens of thousands of lupus patients, or frankly, patients with other conditions, rheumatoid, multiple sclerosis, Crohn's disease, things where you might say, well, if I can draw on their experience, maybe that might teach me something about lupus. Lupus is kind of a smaller community than some of those others. So do people sometimes flare? They do. Do sometimes they have disease worsening after this or frankly any kind of vaccination? They do. But admittedly, your risk to get COVID and bad things downstream of COVID is almost certainly greater than a serious health risk related to a lupus flare. So again, life is about risks and benefits, and the benefit of getting vaccinated and not getting COVID and everything that might come along with COVID, for the vast majority of people, almost certainly outweighs the potential risks. This is something where, it's very reasonable to talk to your healthcare provider about what might be best for you. But again, in the risk balance perspective, I think the vast majority of lupus patients are going to be definitely advantaged by getting vaccinated. The next statement that I wanted to just spend a minute or two on is, should I get the vaccine? It's obviously quite simple. There is a very straightforward, very clear, very concise, proactive recommendation. If you have lupus, you should get vaccinated against COVID. Hard stop. How old do people need to be to get the vaccine? As you're probably aware if you read the news, the emergency use authorization from FDA now goes down to as young as age 12. Kids don't seem to have as bad outcomes, probably not as high at risk for bad lupus or hospitalized lupus, but anything 12 and up is reasonable to go get vaccinated. In terms of what your options are, as you're probably aware if you're connecting with us from the United States, you basically got three choices. You have two mRNA vaccines, that's the kind of vaccine made by Pfizer or Moderna. There's a third option, the J&J or Johnson & Johnson single-dose vaccine. There isn't a preference for which vaccine that you can get according to the ACR guidance task force that I'm the chair of. You might say, well, aren't there some differences between them? There are. One or two of the vaccines, they're two-dose vaccines separated by about 3 to 4 weeks apart. The other is a single shot. Do they work the same? Not totally clear. We don't have head-to-head studies done at the same time to compare them. But the reality is that it's a practical matter. Most people aren't going to have choices. So the best vaccine is the one you can get right now or when you choose to get it. And what we definitely didn't want to do is to say, well, maybe this one could be a little bit better, kind of, sort of, not really sure. And then people might say, well, I guess I should wait until I can get the preferred vaccine, and then they're not protected, and that's not good. So there is no proactive recommendation that you should wait and get one vaccine over another. Most people won't have choice anyway. Again, you and your healthcare provider can talk about the specific pros and cons about whether she or he might prefer one of the vaccines or vaccine platforms, but I think most providers, myself included, by and large, are probably going to say, if you have no choice, just get the one that's available to you right now. What do you do after vaccination? That comes up a lot. Do I still need to keep masking, social distancing? Maybe I need to do more than what public health authorities, the CDC, your state and local guidelines, county health departments are recommending. This was hotly debated because if you'd said, well, wait, if the vaccine might not work quite as well for me because I have lupus, maybe I should be doing all this extra stuff. It's a reasonable thought. On the other hand, we're not positive how well the vaccine works, and to say, well, I need to do all these extra things kind of makes the assumption that it doesn't work well, and that is really an assumption. So I think that common sense, prudence is the order of the day. Follow public health guidelines, follow the CDC's recommendations, but I don't think that fear-mongering to go do a bunch of extra things in the absence of evidence is going to be warranted. But again, talk to your provider about your individual situation. If you work in a very high-risk area, if you are working in a nursing home or in a place where there were large numbers of unvaccinated people that were in close contact, again, your circumstances may vary, and this is a good thing to talk to your healthcare provider about. Another consideration that comes up a lot is whether you should get some sort of lab testing to prove that you are protected or to prove that the vaccine took. This is really tricky because intuitively this just sounds completely reasonable. On the other hand, there's no recommendation to do that. In fact, there's a recommendation not to do that. Why is that? Well, the reason is because we don't know what to test, or at least we don't know how to interpret the test result. There's a couple kinds of antibodies. If you're looking for a vaccine response, you need the anti-spike antibody. That's not what most people think that they should be getting tested with, because early on the antibodies were trying to detect, do I have COVID? That is not the antibody test that you want if you're looking for a vaccine response. That's the nucleocapsid antibody that helps you know, did I have COVID or have I recently been exposed? The test you want to look at vaccine response is spike antibody or anti-spike antibody. Sometimes it's hard to even know what is the COVID antibody test that I can order as a provider. And in fact, the one I have at my own institution, I know it's not the spike antibody, but it took a lot of sleuthing to figure out what is this antibody even testing for. The other tricky problem is, what do I do with the result? There's no cutoff that says if you're above this, you're protected, and if you're below, you're not protected. This is the main reason why antibody testing is really tricky. If I get a number back, I don't know what to do with the number. It's not like I say, if it's above X, things are good, I don't need to worry. If it's below, then I need to worry, and then what do I do about it? So how to interpret whatever some antibody test tells me is really a sticky wicket, and we don't know what to do with that. So for that reason, there is no routine antibody testing that's recommended. There's some extreme cases where if somebody makes no antibody whatsoever, I might worry, and frankly I do, and I have a few patients that brought me tests that somebody else ordered that causes me concern. However, I would point you to the fact in the main pivotal trials, there were people who actually didn't make antibodies but were still protected against infection. You might say, well, how can that be? I would remind you, if this was covered in some biology class that you took, that you may or may not recall the details. So the part of your immune system that protects you against viruses is not the same part that protects you against bacterial infections. It's mostly not the antibody side of your immune system. That's how somebody can not have detectable antibodies and could still be protected against the virus. So again, the interpretation of that testing is very tricky. One last big topic, and then I'm going to go to some of the Q&A that's come in. So there are several medications where the timing of when you take those medicines in relation to when you get vaccinated is pretty important. So Cellcept or mycophenolate, methotrexate, which is sometimes used for the arthritis that goes with lupus. Cellcept or mycophenolate is used for a number of manifestations. Rituxan or rituximab, that's the IV infusion, given every several months usually. So there's a handful of medicines that you might want to temporarily pause or hold or get the timing right that are relevant as to vaccine response. So talk to your healthcare provider. The link I gave you suggests how long some of these that you might need to hold. For some of them, like Benlysta, there's no recommendation to hold. Probably Benlysta doesn't meaningfully blunt the vaccine response, but for some of them, you may get a little bit better response if you adjust the timing a little bit. And then finally, the last thing I wanted to cover is just a few of the myths that sometimes I hear or common concerns. A couple of them go like this. Because I have lupus, I shouldn't get the vaccine. None of them are safe for me. It won't protect me. We've kind of walked through a lot of that, but in fact, that is in fact the counter argument about why most people should get vaccinated. Because COVID seems to be a little bit worse or more severe for patients with lupus and who are on certain therapies, higher dose prednisone above 10 milligrams or people on rituximab, that's actually the reason that they should get vaccinated and that they should be prioritized. And that's what we try to do to advocate for patients, to say, hey, lupus and other rheumatic disease patients, they need to get a little bit up in the queue if they want to be vaccinated. The disease flare and the potential downside of worsened autoimmune manifestations, again, something to talk to your provider about, but by and large, many of those same things, in fact, most all of them, and even some worse things have been seen to ensue after people get COVID. So after you get COVID infection, there's a whole host of antibodies that go crazy in people sick with bad COVID. There's some new emerging science showing that people's autoantibody profiles just blow up after cases of severe COVID. So the immune system is not happy if it sees infection, and that's almost certainly going to be worse than some of the things that I think people are commonly fearful about for their disease, particularly if their disease is starting under control. So a few things that came in then lastly from the community, how long after I have COVID, for those that develop COVID, should lupus patients wait to be vaccinated? The recommendation is you can wait about 90 days. It doesn't need to be more than that. It's not a requirement. Nothing bad is going to happen. That's based on the observation people can get COVID again. Just because you've had COVID doesn't mean that you're protected. You should get vaccinated. You probably don't need to be vaccinated within 90 days just because it's rare, not unheard of, but it's rare that you would get COVID again within 3 months. But you should get vaccinated. Probably good to wait more than 90 days though. If you had the antibody treatment for your COVID, you definitely should wait 90 days just to kind of let that clear. There was a question that came in, what's recommended for patients on prednisone who are diagnosed with COVID? So higher dose prednisone is definitely a risk factor for worse COVID outcomes. That might be because of the fact that higher dose prednisone, more than 10 milligrams a day, really does influence the immune system in a negative way. On the other hand, maybe it's just that it's really bad lupus, and that if that's what you're treating, higher disease activity is not good for the immune system. It's not good in the setting of active COVID infection. So to the extent that you and your provider can wean off or taper prednisone to the lowest effective dose, that would be desirable. There were a couple of questions related to whether there's some different protocol for lupus patients getting vaccinated compared to other patients with autoimmune diseases. It's not specific to the lupus disease. It's all related to treatment. So, if you're on certain therapies, for example, you're on hydroxychloroquine or Plaquenil, same thing, and if that was it, there would be no different protocol as to how you get vaccinated. On the other hand, if you're getting rituximab infusions or if you're on CellCept, there would be something different that probably you and your provider want to strongly consider doing to adjust the timing or having a temporary pause in those medications for a week or two. So it's not because you have lupus, it's really related to maximizing the expected benefit of vaccination. It's not a safety thing that would make you hold your CellCept for a week or two or your rituximab timing. It's more related to those treatments. There was a question that came in about, does our immune system fight COVID any differently because I have lupus? The short answer is yes. Not totally clear the clinical relevance, but as I mentioned, severe COVID, hospitalized COVID, does really make the immune system go a little bit haywire, and there's large groups of antibodies that really go crazy and kind of skyrocket. A lot of that's transient. The clinical relevance in any given person, a little bit hard to sort out. And then finally, there's a whole lot of things that we know that we don't know. So there were a handful of other questions related to, how long does it take to recover? What do we do about, treatment for COVID with respect to the antibody treatments or some of the newer therapies? Baricitinib, which is Olumiant, should I get that? Should I not get that? There's some other cytokine inhibitors or biologics that have been studied as treatments. Hydroxychloroquine or Plaquenil kind of came and mostly went with respect to a treatment. There's really just not a lot of data about many of those things that might be specific or at least different in lupus patients. Obviously, we need more population-based data in general about COVID vaccination, but clearly we very specifically need it for patients with lupus. There were a handful of questions that came in, and to summarize a bunch of them, boosters. Super important topic. I personally am incredibly excited about the booster topic. Do I personally think we will need boosters? Yes, I do. Are we at that point yet? No. There's a whole host of variants on this question. Do I need a booster related to the Delta variant? Is it better to get a booster of a different kind of vaccine or vaccine type than your first one? maybe. We don't know that. So my personal thought is that we probably will need a booster. People who have been vaccinated, that's likely not the last time that you'll ever need vaccination. Who should get it? Do I think lupus patients will be among the first in line who should get it? Probably, because again, I don't expect this vaccine to work quite as well, nor to last quite as long because you have lupus. But how long the vaccine lasts, even in the general populace, isn't entirely clear. So open question and really a bookmark for the future about boosters, but I think that's very likely. There were some questions about, kids under age 12, when they might be offered. My shorter answer is I don't know, but as somebody who has children, my daughter, who was 15 when this was available, I wasn't incredibly unhappy that she couldn't get it yet. She doesn't have an autoimmune condition. Smaller children seem to shrug this off if they don't have chronic illnesses and don't have chronic lung conditions. But, asthma, that would give me some pause as well. I'm scrolling through the questions. If you have other questions or things that you want to cover, I'm glad to address that. I'll address one or two more, and then we'll probably come to the end of the session. One person wrote in or posted that she was likely allergic to both the Moderna and the Pfizer mRNA vaccines. She didn't want to risk a reaction. As you may know, if you've gotten vaccinated, the recommendation is to wait probably half an hour after you've gotten vaccinated just to make sure that everything is worked out okay. Something to talk about your personal situation if you do have a significant history of allergies to other medical products, vaccines, things like that. There were some questions about fertility concerns and the vaccine. As best we know, and as summarized by the Center for Disease Control, this really isn't much of a concern long term. That said, we don't have much long-term data. So that said, I think that the risks due to getting COVID and preventing that and preventing autoimmune manifestations after you got COVID infection, that would give me personally a great deal of pause. But we don't have evidence that fertility is impaired or somehow damaged for people who are getting vaccinated. The last question or two before we're out of time. So one question that has surfaced is, what kinds of research is ongoing? I think all the things that I just described that are unknown or that have yet to be elucidated, are we certain that if you hold some of the lupus medicines I described, that's going to boost vaccine response? No, we're not certain yet. That's an area of active research. Just because a medication for lupus blunts vaccine response doesn't necessarily mean that you can hold it for a week or two and expect a better response. That might be true. We know that for some other autoimmune diseases, it's not a certainty for patients with lupus, but that's one area of active investigation for this. It looks like I've covered most of the questions that I was able to recently to briefly scan here, and it looks like we're even a minute or two over for the time that had allocated today. So thank you so much. As I understand it, this is going to be posted online for offline viewing, and the community is able to field questions or have follow-ups if there were some things that weren't quite answered. Look also at the chat window where I've posted the link to the American College of Rheumatology's guidance statements. That goes into great detail, particularly about some of the specific medicines that you can find which ones you're on. Medicines like leflunomide, hydroxychloroquine, low-dose steroids, no recommendation to interrupt your lupus treatments if you're on one of those. Likewise, Benlysta, either by injection or infusion, but for some of the others, there are some timing considerations that are relevant. So thank you again so much. Hopefully this has been useful and helpful and will complement some of the discussions that you've been having with friends or family or with your healthcare provider. Thank you again.